Good evening, everyone. My name is Deborah Pora. I'm a nurse practitioner and project manager here at VCU in the Pauley Heart Center. I'm excited to welcome everyone here for our new cardiovascular medicine primary care provider CME series, which takes place the third Wednesday of each month through 2025. Tonight is our second month. Those who haven't registered, you can only need to register once through Zoom for the entire series. And you can claim your CME credit for this session. To claim the credit, you should text the code 36730 provided at the beginning and the end of this presentation to 804-625-4041. And I put that information in the texting chat here in our Zoom series right here. For those, if you have any questions accessing your cloud CME through VCU, you can visit vcu.cloud-cme.com, or you can email me. My email is pretty easy. It's deborah.pora@vcuhealth.org. And I'll put, again, that information's in the chat. I also have put in the chat our site for our YouTube for the Pauley Heart Center. So all of our CME updates will be there for your viewing. It is my pleasure to introduce two outstanding providers here with our VCU structural heart program who have been instrumental in driving growth, quality, and efficiency within our program here. First, we have Delia Endicott, nurse practitioner who serves as our structural heart coordinator. Delia has been with VCU since 2001 and has extensive experience in cardiothoracic surgery and cardiology. She completed her training here and graduated studies right here at VCU. And her dedication to patient care and the program development has been valuable, shaping our success of our structural heart services. Also joining us is Dr. Zachary Gertz, our medical director of the cath lab and the structural heart program. Dr. Gertz was trained at Harvard and the University of Pennsylvania before joining VCU in 2012. His leadership and expertise have been critical in advancing our innovative procedures and ensuring the highest quality care that we're giving to our Virginia patients. We're fortunate to have both of them to share their insights tonight. Please join me in welcoming Delia Endicott and Dr. Zachary Gertz.
Delia, you going to get started?
Yep, I will get started. So good evening. Thank you so much for joining us. We're going to cover a few things today with regards to structural heart disease. In particular, our focus will be on valvular heart disease. The two valves that we will primarily focus on will be the aortic valve and the mitral valve, because those are the valves which are most amenable and have the best therapies for catheter interventions. We'll talk about the current therapies that we use in our practice, and then we will also briefly touch at the end on evolving therapies for valvular heart disease. So just the basics. So structural heart disease. So what Dr. Gertz and I primarily work with is structural heart disease. So looking at defects in the heart that involve the valves, the walls of the heart, and the chambers of the heart. In particular, we focus on congenital heart disease. So we have the ability to repair with catheters and other devices. ASDs, which are atrial septal defects. That's the defect between the upper chambers of the heart. PFOs, which is just the little flap that doesn't close when we're born. VSDs, ventricular septal defects. We also treat aortic stenosis, which can be bicuspid aortic stenosis, and pulmonary valve stenosis. Those are the primary congenital heart defects that we treat. For degenerative disease, we focus on calcific aortic stenosis. So that's basically senile or stenosis that develops over time with the aortic valve. And mitral regurgitation, which is degeneration of the mitral valves causing significant leaking of that valve. So these are the current catheter-based therapies that we use in our practice. So primarily, Dr. Gertz does TEER, which is the transcatheter edge-to-edge repair, also known for most people as MitraClip, but actually more accurately described as M-tier. Devices that we use that can be used to repair these valves are MitraClip and the Pascal system. We here at VCU primarily use the MitraClip, and also T-tier, which is the TriClip that can be used for repair of the valves. We have done transcatheter aortic valve replacement. Our primary device that we use here is the Edwards S3 valve. And currently, we have the ability to do transcatheter tricuspid valve replacement as well. Following that, there are definitely some experimental catheter-based therapies that are in development. So remodeling devices that can be used to change the geometry of the heart, primarily used to treat heart failure, stem cell delivery, transcatheter mitral valve replacement, transcatheter flow devices, and iatrogenic atrial septal defects that are used to treat heart failure. So I'm going to focus on a case study first to introduce aortic stenosis. So this case study involves a 99-year-old male. This patient was initially hospitalized after a ground level fall. His other past history is significant for coronary artery bypass grafting with edema to the LAD in 2014, high blood pressure, CKD stage 3B, chronic anemia, prostate cancer, and aortic stenosis. When he was hospitalized with this ground level fall, the patient wound up with a periprosthetic hip fracture. While he was there, they were able to do a revision of that his hip fracture with a hemiarthroplasty. He also had acute on chronic anemia, an acute inferior wall MI post-op, cardiogenic shock, which was treated with packed red cells, Ranexa, and PRN nitroglycerin. Obviously, he was considered to be very high risk. They decided that a catheter-based therapy was not the best way to go to try to treat his MI, and so he was just managed medically. During this hospitalization, the patient had a transthoracic echocardiogram, which showed an EF of 50 to 55%, severe hypokinesis of his basal inferior, mid-inferior, and apical septal walls, which are consistent with his MI. It also showed that his aortic valve was severely calcified, had a mean gradient of 36 millimeters of mercury, a max gradient of 61, and an aortic valve area of 0.6. And you can see, Dr. Gertz can kind of cover, you can see like how calcified that aortic valve is. So this patient was referred to us by his primary cardiologist for evaluation for consideration for transcatheter aortic valve replacement to treat his aortic stenosis. His primary symptoms, the patient had chest pain with exertion. He denied any pre-syncope or syncope, denied dyspnea with exertion. Amazingly enough, this gentleman was still, was active in his rehab and was able to ambulate rehabbing his hip. Medicines for the patient included aspirin, Ranexa 500 milligrams every 12 hours, and rosuvastatin. They decided not to treat his angina with nitrates just because of the severe AS. So this patient was actually deemed to be appropriate for a transcatheter aortic valve. He had suitable vasculature. And so in July of 2024, this patient underwent an uncomplicated procedure, and his aortic valve was replaced with an S3 26 millimeter valve. This is his post-procedure echo. And you can see that his aortic valve is opening and closing well now. The stenosis has been addressed. Post-implant mean gradient was 5 millimeters of mercury, and his aortic valve area was 2.3 centimeters squared. I'll also add a little tidbit in here. This gentleman, as you saw, he was 99. He actually was able to celebrate his 100th birthday last November, and I was fortunate enough to be there for that celebration.
All right. So that's a great case and a great entry point for us. And I just want to echo what Deb said and welcome everybody. And thank you for spending your late afternoon, early evening with us. I'm going to go through just some basics of aortic valve disease, aortic stenosis, and TAVR. Please feel free to interrupt me. I think this is mostly a primary care group, so if I'm above or below your expectations for primary care, please stop me and tell me what I can talk about that will be most helpful. Quick anatomy review. This is the heart. This is the left ventricle, the chamber that pumps all the blood, and this is the aortic valve, which lets the blood out and stops it from coming right back. And if you took a cross section of this, here is what you would see. This 3 leaflets looks kind of like a Mercedes sign. Your coronary arteries come off of 2 of these leaflets, and it should be opening and closing to let the blood out, and it's very thin. It's like tissue paper. And this is a 3D echocardiogram showing a valve opening and closing. This highlight or yellow color does not actually occur in nature. It's just to show you that this valve is opening and closing well. And this is a transthoracic echocardiogram. This is how we're used to seeing the world. And here we see a cutaway. This is the left ventricle. This is the aortic valve. This is the aorta out here. And you see 2 of the 3 leaflets here opening and closing. It's a nice thin line. It opens all the way. This is a healthy person. And then here is what aortic stenosis looks like. You get all these goombas forming on your valve, and it weighs it down. And here's what that looks like on echocardiogram. Again, the left ventricle's over here, the aorta's out here, and here's the valve. And whereas before in the healthy heart, we saw thin leaflets that were opening and closing all the way, now we see all this bright, this is calcium, and all this other junk that is weighing this valve down and stopping it from opening and closing together. The prevalence of valvular heart disease is a bit hard to say, and that's where a lot of our primary care colleagues will come in, is making this first diagnosis. This is a study that was done in England where they tried to get an echocardiogram on everyone in Oxford County, and you can see the blue is patients with known valvular heart disease, and the red is patients with unknown, at least moderate, if not severe, valvular heart disease. The green is mild, but frankly, if we echoed all of us, I'm sure I've got some milds in there already, but I would say it's still about half at least underdiagnosed. So probably it's higher than we think. Usually the number we say is about 5% of patients in their 70s will have aortic valve disease, and maybe 10% if you get even later into your 80s, but probably those numbers are higher than we think. How does it occur? What's the etiology? The most common is what's often called senile or calcific. It is similar to atherosclerosis. It's caused by inflammation, lipid or fat deposits, and calcification or bone formation processes. I would say compared to atherosclerosis, we get a lot more of this bone formation stuff. There are congenitally bicuspid valves, so instead of having those 3 leaflets in that Mercedes sign, there's just 2 leaflets. Those patients don't present necessarily in childhood. In fact, they usually don't, but they have a quicker process of developing aortic stenosis when they do, so they'll present more in their 50s and 60s compared to 70s and 80s for most of our other patients. Rheumatic, really, I'm not sure I've ever seen a true severe rheumatic aortic stenosis. Congenital, usually when you say that, you mean unicuspid valve, which again, super duper rare, and then other rare causes, although not so rare, but lupus and radiation. So patients who have had either mediastinal radiation or maybe left breast radiation. What is it exactly that's happening? I think we saw that valve not opening and closing well. I have 2 analogies I use with patients. One is when you put your thumb on a garden hose and the water sprays in the air, and the other is a door that won't open. Either time we are pushing hard on something to get it to open up. And you'll see the pressure in your left ventricle, and that's this tracing, and the pressure in your aorta. When your aortic valve opens, the pressure should be the same, right? There should be a nice wide open door, and the pressure on either side of that door shouldn't be different. But if the door's not open all the way, there will be a pressure buildup. And these lines are all the pressures during systole, and you take an average of all these numbers, and that is what the mean gradient is. And then we do a bunch of math, and we get to what the valve area is. This is a classic cardiology slide, first published, I believe, back in the 60s by someone named Eugene Bronwald and some of his colleagues, just looking at the natural history of aortic stenosis, and this is sort of a natural, healthy survival curve. And then this is what happens when those patients with aortic stenosis become symptomatic from it. And you can see it's a pretty rapid fall. It is one of the more deadly diseases out there. And one of the first questions that patients are always going to ask you is, are there any medical therapies for this? And the answer right now is no. Maybe in 5 or 10 years, there might be something that comes along, but for now, no medical therapies. And this is a series of studies. This is a sort of a meta-analysis of studies looking at whether patients with severe symptomatic aortic stenosis, so those patients who are about to fall off that curve, were getting treated. And this is before TAVR, and you can see the answer was no most of the time. This is the best American study, and again, 60% of patients were not getting treated. And because of that, aortic valve disease was a rising cause of death. This is the 1970s through the just almost to 2010, just deaths from valvular heart disease. And here you can see rising deaths from aortic valve disease. Very rare to have something with increasing deaths like this. It's not that aortic valve disease was becoming more deadly. It is just that we were doing such a good job at stopping patients from dying from other things, and yet we were not stopping them from dying from aortic valve disease. And I would ask you just for one moment to memorize the shape of that curve. Maybe close your eyes and reopen them here now on this new slide, which just shows age of mortality. So again, this is the same as that curve for aortic valve disease, and you can see it is only going up in this population in the 80s. So like I said, aortic valve disease did not become more deadly. It is just that we were keeping patients alive longer and longer, and there was not a treatment for that. Luckily, TAVR came along. TAVR stands for transcatheter aortic valve replacement. It is a valve that is mounted inside of a big stent, so that the tissue inside this valve will be the same tissue that goes in a surgical valve, but instead of being on a sewing ring that gets implanted in a heart via an open heart surgery, here we're going to take this stent, we're going to crimp it down small on a balloon, small enough to get that balloon through a catheter in the leg, and we're going to put this valve inside of the old valve and inflate it. This just shows the progression of the devices. This was the first device that got put into humans. We're now up to this 3rd generation. These two valves are both available now, and they work great. I will show you one quick video of a valve deployment. There's a lot going on. Don't worry, there's not going to be a test, but we do rapid pacing to essentially stop the heart. We take a picture with this pigtail catheter, and then here is that stent on a balloon. You can see the outline of the balloon. You can see the stent, and the valve tissue is on the inside. And when this balloon goes down, the patient has a brand new valve. It's a pretty amazing procedure. The first papers were published in the early 2010s. These 2 papers were in patients who were considered high risk or inoperable. And then in the mid 2010s, there was a study for patients who were intermediate risk or medium risk. And I'll show you in a minute the low risk study. But I think it's worth just going over for a minute some data from this first study. So this is patients who were not candidates for open heart surgery. So they were randomized to either get TAVR or nothing. And you can see the mortality, and at 2 years was the primary endpoint. So we'll just focus right here. But regular therapy had a 68% mortality, and TAVR had a 43% mortality at 2 years. These are older, sicker patients, so don't be shocked that the mortality was that high. I'll show you later, it's come down as we've done lower risk patients. But just to focus here for 1 second, a 25% risk reduction for death. There is nothing else in a large randomized trial that has ever prevented patients from dying as much as this. 25% means your number needed to treat is 4. I assure you there's nothing that any of us are doing on any given day that you are going to save a life out of every 4 patients at 2 years the way this does. This is called a landmark analysis. This just means, forget whatever happened in that first year. Now let's go to starting at year 1, everyone who's still alive, and see if TAVR was still beneficial. And you can see the curves keep separating. And what this means is that patients with severe symptomatic aortic stenosis are dying from it every day. There's no amount of survival where you say, oh, you've made it 2 years. It turns out you're okay. You don't need your valve replaced. You always need your valve replaced. It is a constant risk of death. And then especially with the older, sicker patients, one of the most important questions we would get is, does it improve their life? We know it prolongs their life. Does it improve it? So this is Kansas City Cardiomyopathy Questionnaire. Higher numbers are good. A 5-point improvement is considered clinically significant. So a patient walks into your office, they've improved 5 points on their KCCQ test. You can tell, and here in TAVR, you can see huge benefits, 25 points a year. The number needed to treat to be alive with a 5-point improvement was 3. So a life-saving therapy for patients who need it. And I think we could probably talk about aortic stenosis all day. And I would be happy to if anybody wants to give me a call later. But I think in the interest of moving on to our other valvular diseases we want to get to, I'll finish up there for aortic stenosis with a couple of just sort of take homes for primary care. First is, if you hear a murmur at the right upper sternal border, it's probably aortic stenosis. By the time you can hear it, it's probably at least in the moderate range, so it's worth checking. Symptomatic patients need their valves replaced. Again, symptomatic severe aortic stenosis has a high mortality. It's about 50% at 1 to 2 years, depending on how sick the patients are. There are patients who still should have surgery and not TAVR. We're not going to get too far into those weeds. I would say we have a multidisciplinary clinic at VCU, and I know a lot of big institutions have them, so we can give patients the full spectrum of options in one visit. So as I said, TAVR is appropriate for many patients, and you will see this all over the guidelines if you read them in cardiology and cardiovascular surgery now, but heart team approach. So again, multidisciplinary team. Our team includes, of course, Delia, who is overseeing everything, cardiac surgery, interventional cardiology. There's at least 2 of us in every specialty. We have access to vascular, we have specialized anesthesia and radiology. And I think that is what is best for our patients. And with that, I'm going to turn it back over to Delia for another case.
So moving on to our next case. So this case involves a 70-year-old male, past medical history significant for coronary artery disease with a history of a 3-vessel bypass surgery in 2001, and then subsequent PCI in 2006. The patient actually had a VT-VF arrest in 2022 and had an ICD implant, which was later upgraded to a CRTD. Patient with persistent atrial fibrillation, history of an AV nodal ablation, PVCs, hypertension, HFrEF with a reduced EF 30%, NYHA class 2 heart failure symptoms. Before the patient actually got to us, he was seen by heart failure, and they really did a great job optimizing his medical therapy. So he was on guideline-directed medical therapy. He was on Entresto, moderate tier 2 dosing, a beta blocker with Toprol 100 milligrams daily, aldosterone antagonist, so spironolactone 12.5 milligrams daily, a diuretic, a PRN, and then he was also on an SGLT2 inhibitor, Farxiga, 10 milligrams daily. The patient underwent a transthoracic echocardiogram in November of 2023. He was noted to have an EF of 30 to 35% with some LV wall hypokinesis and basal wall inferior akinesis. He had a global longitudinal strain of negative 9.1. That's actually just a very sensitive marker for somebody's cardiac function, a little bit more finely tuned than just the EF. He was found to have moderate to severely dilated left atrium. And then his mitral valve had severe regurgitation without mitral valve prolapse. These are just some of the dimensions of his heart. So pretty dilated left atrium. His LV was also dilated. And then these are some parameters with regards to his mitral valve with his MR and his MV jet. This is an echo, just kind of showing just how severe that regurgitation is. You can see by all that color in the middle. Then this is on optimal medical therapy. He still had, severe MR. So it was decided to repeat his TTE after he had his is CRTD placed and optimization of his GDMT. Initially, it appeared that he had an interval improvement in his EF from 30% to 45 to 50%. A little bit of aortic stenosis with a mean gradient of 22, still with severe MR with a posteriorly directed jet, dilated IVC indicating elevated right atrial pressures, and then some mild pulmonary hypertension with the RV-SP of 28. Still, his LV was pretty dilated and his gradients on his MR were still pretty high. This is just more pictures, just kind of indicating the severe MR that's still present despite interval improvement in his EF and then ongoing, guideline-directed medical therapy. For this patient, there was some suggestion that perhaps fixing his PVCs might help his MR. So it was thought that he would go for a PVC ablation. However, when the patient went for that ablation, they were unable to induce any PVCs. So the patient was then referred to our team in the structural heart disease clinic. His primary complaint was actually of exertional angina. When we interviewed the patient, we decided that maybe the patient needed an ischemic evaluation to see if his angina was actually related to his coronary disease, given his history. And his left heart cath actually did not really reveal any new obstructive coronary artery disease. So the patient then presented to us for a MitraClip procedure. This is a pre-procedure echo done, and you can see his valve with the regurgitation. And this is post MitraClip. You can see that he now has a double orifice. So you can see that the clip is centrally located here, pulling the two leaflets together, which has substantially reduced the orifice area to reduce his regurgitation.
All right, so I think that's a great segue into talking about mitral valve disease. I like to show a couple of these slides just to talk about how complicated the mitral valve is. Don't worry, there will not be a test. If there was, I'm not sure I would pass it either. The important components of the mitral valve, there are two leaflets, the anterior and the posterior. They are held down by these cords to papillary muscles, and the muscles are part of the left ventricle. And here's just some gross anatomical views of this. Here's the left atrium, the left ventricle. Here's leaflet tissue, cords, papillary muscles. This is just a cross-sectional. So here the left ventricle is over here, anterior leaflet, posterior leaflet, cords, and lots of other stuff going on. There are two FDA-approved devices, as Delia mentioned. By far the biggest market share is this one here, which is called MitraClip, which is why most of us still just call the procedure a MitraClip, but technically we should be calling it transcatheter edge-to-edge repair. And I like to show this this quote. I don't know if any of you have ever read Anna Karenina. I haven't either, but I do know the first line, which is, happy families are all alike, but every unhappy family is different in its own way. And I like to apply this to valvular heart disease because I think every aortic stenosis case is about the same, but every mitral regurgitation case is different and unhappy in its own way. So the first and I think maybe the most important question we have to ask with mitral valve disease is, what is the mechanism? What is the etiology? Why is this valve leaking? Again, I showed you there's a million different parts and they can all break in their own way. The most common way we talk about mitral valve disease pathophysiology is sort of on two different axes. One is whether it is primary or secondary. Primary means the valve leaflets, the valve apparatus itself is damaged. Secondary means it's a normal apparatus, but some other force is making things bad. Usually that's going to be a low ejection fraction, a dilated left ventricle. The other way we discuss mitral regurgitation is by what's called Carpentier classification, which just is a description of the leaflet motion. Is the leaflet motion normal, as we see in this picture? Is it excessive, right? That this leaflet is moving too far, it's breaking the plane and going into the left atrium? Or is it restricted? And there's two types, but really don't worry about that. But this is the sort of a post-heart attack heart. You can see they put this scar in the picture, and these papillary muscles are pulled down, and these leaflets are pulled down, and it stops them from being able to close. And you can go pretty far down a rabbit hole with charts and how we do. And this is something from 2017 that I like. But really, we end up in two main places. One is this degenerative group. This is where like I said, the valve apparatus itself is damaged. Here's one of the cooler pictures of this. Obviously, this is a heart that is no longer in a body. I'm pretty sure this is an animal heart. But this is the anterior leaflet and the posterior leaflet. The left atrium has been cut away, and you can see these cords that are prolapsing through because the cords have ruptured. Here's in a still alive patient with that. This is transesophageal echo, so the image is flipped around compared to what we were used to before, but this is the left atrium, this is the left ventricle. Here are those two mitral valve leaflets, and you can see this poor guy is just flopping back into the left atrium because these little strings, these cords that are supposed to be tied down are broken, and then all this color is regurgitation. What should we be doing with these patients? It is a little bit tricky for management. So as opposed to aortic stenosis, where you remember that slide I showed where your survival is pretty much okay if you're not symptomatic, that is not the case with mitral regurgitation. You can see that patients with severe asymptomatic mitral regurgitation still have higher mortality, so lower survival than patients with mild disease. Again, for aortic stenosis, if we put that word asymptomatic there, the curves would be about superimposed. So there are some markers we need to be looking for besides just symptoms to decide when to do this. Again, here's just another pic of symptoms. These are patients with normal ejection fractions. Symptoms for sure are bad for you. So this is survival. If you have New York Heart Association class 3 or 4, we'll just say moderate dystonia with exertion versus less. So symptomatic patients do need to be treated. That was not my point. My point is we need to be treating them in addition to the asymptomatic and finding when. I don't know why that E on conservative fell down there, but the most common way we do this is with the LV size. So the size of your left ventricle. As your left ventricle is handling this bigger pumping load, right? Because you pump blood backwards towards your lungs, we still need to pump some amount of blood forward. So what ends up happening is the amount of blood that's getting ejected with every beat goes up. And depending on the regurgitant fraction, say if it's a 50% regurgitant fraction, your heart might be pumping 1.5 times as much blood out of the left ventricle as it was meant for, and it gets overwhelmed. It's just too much work, and the left ventricle starts to enlarge to accommodate all this extra volume. And you can see all these slides, and we don't have to get into too much detail, but just know that the smaller hearts are doing better, the bigger hearts are doing worse, and usually we'll talk about the end systolic dimension, but again, we can have lots of arguments about exactly which one. But once the heart starts to enlarge, these patients need to be treated. So again, in patients with primary mitral regurgitation, which is the ones we're talking about for right now, these are the guidelines. Again, you're welcome to remember these. You're also welcome to refer them to us. You don't have to wait until the patient needs intervention to refer them to a valve program. We're happy to do the monitoring as well. But again, severe mitral regurgitation with symptoms, reduced ejection fraction. This one I didn't mention, but if there's a good chance that the valve can be surgically repaired, we should go ahead and do it. And then again, if this is, I think, because I stole this from my guidelines updates talk, but some of these other things that probably do still warrant it just got taken out of the guidelines. What about MitraClip for these patients? This was the Everest trial. This was done about 10 years ago. This was MitraClip versus surgery, and surgery won. Surgery won because MitraClip is just not as good as surgery at repairing that valve. There was no difference in mortality, but a fair number of the MitraClip patients, again, the young, healthy ones who didn't get a perfect result from a MitraClip, went and had surgery. For patients who aren't candidates for surgery, though, MitraClip is great. This is data comparing just the high-risk patients who got it in the trials to patients who were managed conservatively, and you can see if we just focus maybe on this slide over here, this is symptoms. Again, class 1 and 2 are good, class 3 and 4 are bad. And you can see the patients who get treated with MitraClip still end up feeling much better. And it did get FDA approved. I will say that's not the end of the story, because as with TAVR and every new technology, the more we do, the better we get. So Everest 2, which is the randomized trial I showed you, which was done in 2010, there have since been a lot more trials, and you can see our ability to reduce mitral regurgitation to an acceptable rate has gotten much, much better as we've all gotten better at the procedure, and the devices have gotten better. And so they are trying this again. This is called the Repair MR trial. It's not finished yet, but they are looking at whether MitraClip tier could be a first option. But for now, I'd say in good candidates for surgery, we send them to surgery. In candidates not, patients who are not good candidates for surgery, we clip them. And whether that changes in the next few years, we'll have to keep an eye on. Okay, let's talk about the more common cause of mitral regurgitation, and that's what we called functional. Remember I said this, that's that heart that's had a heart attack or heart failure from a non-ischemic cause, but a big dilated heart. Here you can see a left ventricle that's pretty big, and these leaflets are getting pulled down, and the valve is leaking. There are two main things that cause this. The easier one for me to think about, at least, is this pap muscle displacement. Remember, those papillary muscles are holding the cords that are holding the leaflets. If you have a heart attack and your heart's getting bigger, this papillary muscle is going to get pulled down. These leaflets get pulled down by these cords, and this valve, instead of closing here like it's supposed to, gets sort of stuck closing only this far. There's also something called closing forces, which we could save for another day. Patients with secondary mitral regurgitation have worse outcomes. So again, low ejection fraction patients, much higher mortality if you have moderate or severe mitral regurgitation compared to patients who don't. So how should we treat them? Well, the first thing we should do is treat the underlying conditions. We need to be putting these patients on optimal medical therapy, cardiac resynchronization from EP. Again, treat the underlying condition. And after we've done that, we should really treat the underlying condition. After you're absolutely sure that we have done everything we can, and again, that means heart failure, EP, if coronary vascularization is necessary, anything else that could be causing heart failure, thyroid, all those things treated, at that point is when we consider intervention. So let's just, for a minute, because I said it so many times, talk about treating the underlying condition. Medical therapies. I don't have spironolactone on here because I don't have Entresto on here because it's newer, but it gets you the same effect as ACE inhibitors. All of the medical therapies that we know work for heart failure shrink hearts and reduce mitral regurgitation. So this is captopril, an ACE inhibitor we don't really use anymore, but you can see in patients, this is a randomized trial, none or captopril, the mitral regurgitation goes down as the heart size goes down. This is a beta blocker study. These are Bland-Altman plots, which are a little more annoying to look at, in my opinion, but it will tell you that the MR volume goes down and the patients who got the beta blocker, and it goes with hearts shrinking. And then this is, I think, the easiest one of these slides to think about for me. This is from several trials of MitraClip. So these are patients who did get clipped, but just looking at whether they were on single, double, or triple therapy, where again, you can see the groups, basically beta blockers, ACE or ARBs, and spironolactone or not, and you got credit for being on Entresto. But patients who are on at least 3 medical therapies have this is rarer and has much better outcomes. So you can see the survival is much better if you have 2 or 3 therapies compared to patients with only 1. So we really need to push hard to be on medical therapy. Again, that does not all fall on the primary care shoulders. We can do that in heart failure clinic as well, but we need to focus on that before we turn to treating the mitral valve. The other study that I like and I like to show, this is just a patients before and after dialysis. These are all patients obviously with end-stage renal, and you can see regurgitant lesions get better and EFs get better after dialysis, which is just my way of saying we should be diuresing these patients pretty aggressively if they're volume overloaded. Everything looks better if we dry our patients out. Again, I think you guys are more than capable of doing it, but we're always happy to help. So now let's talk about MitraClip for these heart failure patients. 2 studies came out in New England Journal at the same time. You can see they're both from the same volume and 10 pages apart. One was called MITRA-FR, and one was called COAPT. And these 2 studies had completely opposite results. Here's MITRA-FR, no difference in death and no difference in hospitalization. And here's COAPT, huge reduction in heart failure hospitalizations and pretty sizable reduction in mortality. Again, a hazard ratio of 0.62 means it's about a 40% reduction in death. That is more than any of those individual therapies that I just showed. If we had an extra hour, I would love to parse these 2 trials for you, but I think this sums it up the best, which is to say MITRA-FR was big hearts without a lot of mitral regurgitation. COAPT was smaller hearts with more mitral regurgitation, and those are the patients who are most likely to benefit. This got FDA approved based on that COAPT trial in 2019. Here's some recent guidelines, which just say patients on optimal medical therapy with heart failure and mitral regurgitation benefit from TEER. Okay, just very briefly for one slide to talk about mitral valve replacement via transcatheter approach. My short answer is it's so complicated, I don't know if it will ever happen. People have been trying ever since the first PARTNER trials came out, over 10 years ago, to design a device. Again, as with all these topics, I would love to chat about it for an hour, but I just don't think we have the time. But the things to worry about is, where are those leaflets going when you displace them? How do you anchor them? The devices have to be much larger because mitral valves are larger. And so it still has not happened. Whether it will ever happen, I don't know. But I would not buy stock in a company whose only goal is to make a transcatheter mitral valve. Again, some take-home points for primary care for mitral regurgitation. First is, if you hear a murmur at the apex, think mitral regurgitation, and it's worth investigating. Do not just wait for symptoms. So patients with moderate or for sure severe mitral regurgitation need a more thorough evaluation to see if it's time to fix it, whether their hearts are enlarged, or if they just look like good candidates for repair. Do think about the etiology. Again, those degenerative valves are mostly going to get treated surgically. Functional valves, we're going to medically optimize, and then think about clipping. I was skipping my own, I was spoilering my own bullet points, but again, degenerative, surgically and lower risk, MitraClip for higher risk patients. Functional mitral regurgitation are the ones we send to heart failure to be optimized, but of course you guys are capable of doing it as well. And as before, you really do always want a heart team. We want to make sure patients are getting a complete evaluation and hearing about all of their options. With the last just few minutes that I have before we open up to questions, I just want to talk about tricuspid regurgitation for a moment, only because it has been in the news a lot in the last year, because a bunch of devices have just come out and some trials have been done. And I just want to give you the quick version of what at least my take on this is. Here's a transthoracic echo. Here you see left ventricle, mitral valve, left atrium, and now we're just going to focus on the other side of the heart. This is the right ventricle. Here's a tricuspid valve and a right atrium. And you can see this tricuspid valve has all this leak that's coming backwards. The anatomy gets even more complicated for a tricuspid valve. It's called tricuspid because it has 3 leaflets as opposed to the mitral valve, which I thought was complicated enough. Tricuspid valve will have a septal anterior and posterior leaflets, but as this slide tries to tell us, if you guys can understand it, we can have all different sizes of these leaflets and all different positionings, and there's even more ways for things to go wrong. When we talk about tricuspid regurgitation, we have to use a different scale. So usually for mitral regurgitation, it is on a 4-point scale. We say pluses, I don't know why, but 1 plus 2 plus 3 plus 4 plus. Tricuspid, we had to invent 5 plus, and 6+, massive and torrential, which is why I have this spinal tap reference. Hopefully a few people got it. You can do tier for tricuspid regurgitation. It's, T tier. The imaging is much harder for tricuspids than it is for mitrals. We all have to talk about what we're looking at. Here is a clip that has been placed, and you can see less leaky. For tricuspid tier, they talk about just getting 2 grades better. So if you start at 6, a 4 is considered a successful result. The tricuspid clip trial that just got finished was called Triluminate. It is the same MitraClip device with a couple of tweaks to the delivery system just to make it spin differently. The device they call is a TriClip. This paper got published in New England Journal and presented just recently. A couple things that I would note about this, and I point out to everyone, these were almost all patients with atrial fibrillation. So this was not your typical tricuspid regurgitation patient. It is a narrow group of patients who were candidates for this therapy. And I think most importantly, there was no difference in their primary outcomes of death or tricuspid valve surgery or heart failure hospitalization in the patients randomized to the device or medical therapy. So patients are not dying from tricuspid regurgitation. It can be a marker for other disease states. Again, they didn't include patients with severe pulmonary hypertension. If your pulmonary hypertension is giving you tricuspid regurgitation, it's a very bad sign. But treating the tricuspid regurgitation does not fix anything. Despite this negative for their outcomes, there was some improvement in Kansas City cardiomyopathy questionnaire. Again, you do a big procedure to a patient and ask them, do you feel better? They sometimes just want to make you happy. This made it into the front section of the New York Times. And the quotes, which I thought were almost insane to me, these are obviously the people who were involved in the study saying how great it was. The primary surgeon said we would never have expected to see a mortality difference, even though for MitraClip there was, and another surgeon saying this was a huge win. I will say a similar trial got done with a valve that's called Evoke. This again was designed to be a mitral valve, just like the MitraClip, but it doesn't really work in the mitral valve that well. So they tried it in the tricuspid. Again, a randomized trial, again published in New England Journal of Medicine. No difference in death, no difference in heart failure or a combined. Again, there were some patients who benefited for KCCQ, cardiomyopathy questionnaire, but I would again argue that you did a big procedure to somebody and just asked them if they felt better. There were no hard outcome differences in either of these, and yet both devices got approved by the FDA. So we are open to doing this treatment. We do have the clip. This Evoke valve has not been rolled out to many sites. There's no commercial sites yet other than a few sites that were the trial, but we do have tricuspid clip. But just to say, as opposed to mitral valve disease and aortic valve disease, where the patients really could be dying and it's important to get them treated as quickly, tricuspid valve disease, I think, is more a situation where when you've got a hammer, everything looks like a nail. And we are open to doing this, but I think much more selectively. And with that, we can turn it back over to Deb or anyone who wants to ask questions. And I thank you all so much for your time.
So we'll open up any questions for Delia and Dr. Gertz. I'm looking in the chat. You could either, take yourself off unmute, or I can read them from the chat. One question I have for Delia and Dr. Gertz, I'm sending a patient to Dr. Gertz in a couple of weeks. How does the presence of atrial fibrillation impact the patient selection and procedure approach and outcomes with the mitral valve clip?
A wonderful question. Thank you. That feels like a plant, but I did not ask you to ask that. But AFib with valvular heart disease is one of my very favorite interactions. Atrial fibrillation can cause mitral regurgitation. It enlarges the left atrium, and that can also cause mitral regurgitation by dilating that annulus where the valve sits. So I always want our patients treated for AFib if at all possible. There are, and you didn't ask me to talk about EP, nor should I, but there are several recent trials showing that heart failure patients with AFib get a huge benefit from having AFib ablation. Now, sometimes they're not candidates, right? If that left atrium is enormous, EP guys are going to say, no, we can't give that a try. But if they are candidates, if they can get them back into sinus rhythm, or if they're having a lot of RVR, you can even ablate their AV node and put in a pacemaker. But if there's any way to treat rhythm stuff, I like to try to treat that first, although sometimes that's me and Ken Ellenbogen going back and forth with me saying you go first and him saying we should go first. So we will always treat the patient, but yes, if you can treat atrial fibrillation, I think it is wonderful for the patients.
Yeah, so the patient I'm sending you is a 30-year-old sickle cell patient with severe MR, having AFib with RVR, very dilated left atrium. I consulted both of you guys
Yeah.
to look at the patient because he's on going into heart failure also. So yeah, I just didn't know who was going to act first on this specific patient.
Yeah, I think we all play a game called Not My Organ, where it's like we say it's a lung problem, lung says it's a heart problem. I think we've gotten so specialized that we say not my system, and EP will say no, you guys should fix it first, and we'll say no, you should fix it first. But we always do something for the patient. We don't delay care to argue over it, and sometimes it's both. I have a patient that we just clipped, who we found out he needed a clip because he developed AFib and he had a flail leaflet, but he just couldn't stay in sinus rhythm while he had that much mitral regurgitation. So I clipped him and he set up for a cardioversion in the next couple of weeks. So somebody can go first. We won't let the patient decline, but I always would prefer if Ken can fix something for Ken to fix it.
Any other questions? So my email is in the chat here. I will make sure I put my email in the chat here. Yes, it is. If you have any questions and referrals or anything else in regards to questions with this update here, I'm happy to send that along. Thank you for all for joining us tonight for this presentation. I want to thank Delia and Dr. Gertz for sharing their expertise for us. Before we wrap up, just a quick reminder that the code on the screen, the 36730 to 804-625-4041, and that needs to be text within the next 48 hours. And then you will have 30 days to do your evaluation on the VCU Health Continuing Education website, which again is vcu.cloud-cme.com. We're excited for this education series to grow across Virginia, and we encourage you to share this with your colleagues. My email again is on there, so I appreciate any feedback you have and any updates that you have for upcoming talks. That would be great. Next month, we are discussing hypertension and resistant hypertension. We have a PharmD who works with nephrology who specifically sees hypertensive patients and will be titrating medications. So I really am looking forward to that talk. We appreciate your time and engaging with us this evening, and thank you again. Have a great evening, everyone.
Thank you.
Thanks, Delia. Thanks, Dr. Gertz.
Thank you. Take care, everybody.
Bye-bye.
Bye.